9. I welcome everyone to week 9. Today we are discussing APRN policy. This presentation is not just necessarily a summary from chapter 62 and 63. It's just a reflection on the strategic maneuvering required to advance our profession. As a family nurse practitioner myself, I've seen firsthand how policy dictates practice. We'll explore, for example, the West Virginia success story and be able to compare it with other states. And I will challenge you to think about your role in this ecosystem. We often fall into the trap of thinking that the data speaks for itself. If that were true, we would have a full practice authority several years ago in all the states or even in Canada. The Institute of Medicine, for example, report was a catalyst. But when you look at the readings, you notice that data is just the starting point. The paradox is that while we are clinically trained to be autonomous, we still face some political constraints. In my own practice, for example, I can diagnose a complex condition, but in some states, a signature requirement delays the treatment. For example, in the states with restricted practice authority. So what should we do? For years, for example, nurses have argued that full practice authority is based on access to care. But for example, when the West Virginia legislature flipped to a Republican majority, that message fell flat. They changed the language and it became about the regulation and free market competition. So as DNPs, we must try to frame the language in a different way. We speak clinical to our patients, but we must also delve into economics and rebate to registrators if that's what they value. One of the most striking takeaways from the readings this week is the coalition building. Who would imagine, for example, AARP and Americans for Prosperity would be on the same side, yet they united over full practice authority. This teaches us that we cannot stay in our nursing silos. We need to build bridges with other groups that might seem unrelated to healthcare, but share philosophical goal with our desired outcome. I've found that community leaders often advocate for us more effectively than how we do it up by ourselves. So the reality of policy at work, it's like a winding road. In West Virginia, for example, they did not get everything they wanted. They still have restrictions on Schedule II medications, for example, but they got the independent prescribing license. Well, it's still frustrating but effective. As clinicians, we are used to immediate results. Prescribe a medication, see an effect. Policy is chronic care management, not acute care. It requires patience and long-term monitoring. Back to the readings, we see different other states, for example, New Mexico and North Carolina. For example, New Mexico had advantage of rural need, which forced the registratures hand very early. So they had to act upon that. North Carolina, on the other hand, shows us the modern playbook, building the bench. We cannot just lobby registrators. We must be also registrators or put ourselves in their thought process. So, for example, we notice Gail, one of the NP from the readings, who transitioned to into a representative, so just so that she can advocate better for the full practice authority. Let's take a look at this quote. Passage of registration is different from implementation of policy. This is very crucial. So what do I want to emphasize from this is that signing the bill into is not the finish line. In New Mexico, for example, when you look at their full practice authority, when it passed, NPs faced barriers from insurance companies refusing direct reimbursement or hospitals requiring physician oversight in their bylaws. So having the legal right to practice does not always translate into positive outcomes for our patients. For example, if an NP in one state cannot get credentialed or get paid, or look at how long it takes to get credentialed in some states. For example, in New York, it may take up to, 3-4 months or even longer. So we must remain vigilant in the corporate boardroom as well as the state house. Let's go back to the story of Gail in North Carolina about building the bench, which means preparing nurses to run for office. I mentioned this in the first few weeks of this course, that we are the most trusted profession, which you are already aware of. Yet we are underrepresented in government. So in my experience, I noticed that, for example, population health requires in negotiating with city councils and zoning boards. These are political spaces. So we need to be comfortable wielding power, not just always asking for favors. So what are the clinical implications of our discussions today? So let's bring this back to the bedside. Why do we care about those barriers in regulation? It's because they hurt our patients. We notice that sometimes you have patients waiting for days for a simple signature on home health orders because the supervising physician was on vacation. In some states, for example, like Texas, that's a failure of the system. We notice like in health professional shortage area, data is just numbers. The reality is a patient driving, for example, for a couple hours for a 15-minute visit. So full practice authority is a patient safety issue. My challenge to you this week is just to look at your own state. What is one specific barrier that you are facing? Is it scheduling, maybe, is it prescribing Schedule 2 medications? Is it home health signatures that I mentioned, for example, in Texas? Once you identify the challenge, don't look for other nurses to complain to. Look for an uncommon ally. Is there a local chamber of commerce, for example, concerned about workforce health? A rural farm bureau? That's where usually the power lies. And here are some of the references you might find useful as you navigate this week's readings. Thank you, everyone. Have a great week.